Medication non-adherence is a major and growing public health concern. 20 to 30% of medications are never filled consistently, and although medication adherence is one of the major factors in controlling and preventing complications of chronic conditions, patients don't continue treatment as prescribed in about 50% of cases. The World Health Organization estimates that by the year 2020, the number of Americans affected by at least one chronic condition who will require medical therapy is estimated to reach 157 million people. In light of these facts, my project focused around gathering evidence to establish the problem of medication adherence and education regarding a suggested text message intervention at a local primary care office. The direct cost of non-adherence in the United States is estimated to be between $100 and $289 billion annually. It can result in lost productivity at work and at home. And in the United States, medication non-adherence is estimated to cause approximately 125,000 deaths, contribute to at least 10% of hospitalizations, and add a significant increase in morbidity and mortality. Implementation of a text message intervention could improve adherence across a myriad of disease states, age ranges, and geographic locations. The purpose of the project was to develop and implement an evidence-based educational intervention pertaining to medication adherence and the use of text messaging to improve adherence at St. Joseph Primary Care in Lexington, Kentucky. There's extensive literature to establish the utility of text messaging to improve medication adherence. In my project, I evaluated one qualitative study and 7 randomized controlled trials. Each were critically appraised and compared to corroborate the use of text messaging in clinical practice to improve medication adherence. Though one potential limitation is the subjective reporting medication adherence, 2 clinical trials actually evaluated biologic measures to assess therapeutic response to medication and compared that amongst text messaging groups and control groups. They found that those in the text messaging group actually had more therapeutic levels of CD4 count and viral load than did the control group. The project was implemented at St. Joseph Primary Care in Lexington, Kentucky. The informed consent letter was provided and each attendee was offered the opportunity to decline to participate. A PowerPoint presentation was used to present information to substantiate the problem of medication adherence, as well as discuss evidence to support the use of text message interventions to improve adherence in clinical practice. Because no formal tool was currently in place to assess medication adherence in their population aside from the traditional interview, the Moriski 4-item medication adherence, or MAQ, was introduced and suggested as a possible tool to integrate into their current clinical practice. The MAQ is pictured on the poster. An infographic was also provided that illustrated the scope and scale of poor medication adherence in the U.S. The presentation lasted approximately 12 minutes and was followed by a robust discussion and question and answer session that lasted about 7 minutes. All materials were provided in printed form to each participant for their review. I was very pleased with the feedback given from the participants regarding the need for educational programs like this in primary care. Though it's understood that poor medication adherence is an increasing problem, none of them were aware of the extensive economic impact created as a result of poor adherence. The participants agreed that better tools are needed to be utilized in their clinical practice to assess adherence, and they liked the simplicity of the MAQ. They did agree that text messaging showed promise in clinical practice, but were uncertain as to how to integrate it. However, they did appreciate knowing that resources already exist that patients can begin using on their own if they so choose to. In evaluating the effectiveness of the project, a few important themes emerged. First, because the topic of medication adherence is so broad, I believe that the presentation may have been better if I had tailored it to meet specific needs of the agency as they pertain to the bigger problem of medication adherence. From there, information to support use of my suggested text message intervention could have been adapted and applied in a much more individualized manner. Second, in introducing the MAQ, I gave only a brief overview. The providers indicated that they would have liked to have more information regarding the development, validation, and applicability of the tool, as opposed to a brief instruction for a tool that they might use in clinical practice. Overall, I was very pleased with the project and how it was implemented. I believe that medication adherence is an extremely important topic that can and should be addressed at all levels in primary care.